In primary care, it is not always obvious if a patient's symptoms are due to thyroid hormone abnormalities. That is why in this video we'll look at how to approach the results of thyroid function tests and how to manage them in primary care. Why do we need thyroid hormone anyway? Your thyroid hormone is the catalyst and regulator for the body's energy stores. It helps to keep the body's energy in a balanced flux. Too much or too little thyroid hormone can affect processes like digestion, heartbeat, growth, and temperature regulation. Thyroid hormones also influence your mental health, impacting mood, memory, and concentration. Your GP is likely to routinely detect thyroid issues during blood tests for complaints of fatigue or tired all the time, weight changes, menstrual and pregnancy concerns, heat intolerance, palpitations, visual disturbance, eye changes, or mental health reviews. It could also be picked up incidentally during NHS health checks or annual reviews, especially in patients on long-term medications or with chronic illnesses. GPs are more alert to thyroid issues in women over 50, where prevalence significantly increases. How common are thyroid hormone abnormalities in the UK population? Hypothyroidism is more common than hyperthyroidism. The average prevalence of hyperthyroidism in the general population is around 1% overall, slightly higher in women and older adults. Our overt hypothyroidism, which includes clear symptoms plus abnormal blood tests, we'll come to this in a moment, is about 2 to 3% of the general population. Subclinical hypothyroidism, where the thyroid-stimulating hormone is above normal but still manages to keep the thyroid hormone levels normal, represents about 4 to 10%, again often more common in older adults and women. That means for every person with an overactive thyroid, there could be 4 to 10 others struggling with an underactive one, many of whom might not even know it. Let's start with hypothyroidism. This condition results from a deficiency in thyroid hormones, specifically thyroxine or T4, and triiodothyronine, known as T3. Hypothyroidism comes in 3 main types. First, there's overt hypothyroidism. In this condition, thyroid-stimulating hormone, or TSH, is elevated, typically above 10 microunits per liter, while free thyroxine, or FT4, falls below normal levels. Next is subclinical hypothyroidism. Here, TSH levels are elevated, but T3 and T4 remain within the normal range. Finally, we have secondary hypothyroidism, also known as central hypothyroidism. This occurs when TSH levels are inappropriately low or normal, but FT4 levels drop below the standard reference range. This is much less common. Now, let's talk about what causes hypothyroidism. Primary hypothyroidism can stem from several factors, including iodine deficiency, autoimmune thyroiditis, post-surgical complications, certain medications like amiodarone and lithium, transient thyroiditis, and thyroid infiltrative disorders. On the flip side, secondary hypothyroidism is typically caused by disorders affecting the pituitary gland or hypothalamus. Symptoms of hypothyroidism can range from mild to severe and may often be non-specific, especially in older adults. Common signs include fatigue, cold intolerance, weight gain, constipation, and depression. Prolonged untreated hypothyroidism can cause further complications in the body. These may include dyslipidemia, metabolic syndrome, coronary heart disease, stroke, heart failure, neurological impairments, and adverse maternal and fetal outcomes during pregnancy. So, how do primary care clinicians assess someone for suspected hypothyroidism? It involves a multi-step process. They should first inquire about symptoms, non-thyroidal illnesses, medications, and any risk factors such as family history or autoimmune diseases. Next, they'll examine for signs of hypothyroidism, like thyroid enlargement or nodules. Blood tests are done, beginning with measuring serum TSH levels. If those are elevated, FT4 should be checked from the same sample. In some cases, repeat thyroid function tests might be necessary, and additional tests for thyroid peroxidase antibodies may be arranged if indicated. When it comes to managing overt hypothyroidism, the approach depends on the severity of symptoms. This includes emergency admission if serious complications like myxedema coma are suspected, and arranging an urgent referral to an endocrinologist for suspected secondary hypothyroidism. Generally, treatment typically starts with levothyroxine or LT4 monotherapy, an ongoing monitoring of symptoms and thyroid function every 3 months. Once TSH levels stabilize, annual checks are then recommended. For those with subclinical hypothyroidism, management also includes starting levothyroxine treatment based on TSH levels, age, and symptom presence, along with regular follow-up. If during a follow-up blood test the thyroid peroxidase antibodies are positive, it suggests that the patient is more susceptible to developing overt hyperthyroidism, therefore regular monitoring may be indicated. In these patients, treatment with levothyroxine may be trialed if symptoms are significantly affecting quality of life. If you're planning a pregnancy, are currently pregnant, or are postpartum, your GP will consult with an endocrinologist regarding initiation and adjustments in the treatment plan when necessary. How to assess a patient with suspected hyperthyroidism. Hyperthyroidism is a condition characterized by the overproduction and secretion of thyroid hormones by the thyroid gland. While hyperthyroidism refers specifically to this increased hormone production, the term thyrotoxicosis describes the clinical symptoms that arise from excess circulating thyroid hormones due to various causes, including hyperthyroidism itself. When we talk about primary hyperthyroidism, we're referring to cases where thyrotoxicosis results from abnormalities within the thyroid gland itself. Common examples include Graves' disease or nodular goiter. In these cases, we can identify 2 types of hyperthyroidism, overt and subclinical. Overt primary hyperthyroidism is diagnosed when the levels of thyroid-stimulating hormone, or TSH, are suppressed below the normal range while free thyroxine, FT4, and/or free triiodothyronine, FT3, levels are elevated. On the other hand, in subclinical hyperthyroidism, although TSH levels are low, FT4 and FT3 concentrations remain within normal limits. It's also important to note that sometimes we encounter thyrotoxicosis without hyperthyroidism, which occurs when the thyroid gland isn't overactive. This can happen temporarily due to conditions like thyroiditis, which is inflammation of the thyroid gland, or excessive intake of levothyroxine. What are the complications of hyperthyroidism? Hyperthyroidism can lead to serious issues such as thyrotoxic crisis, Graves' orbitopathy, compression symptoms like voice change caused by a large goiter, and even cardiovascular problems like atrial fibrillation and heart failure. Your GP will consider hyperthyroidism in individuals presenting with symptoms like anxiety, palpitations, tremors, weight loss, diarrhea, and heat intolerance. Physical signs to look for include agitation, sinus tachycardia or fast resting heart rate, goiter or thyroid nodules, and specific features of Graves' orbitopathy like excessive tearing, double vision, changes in visual acuity, eyelid retraction, and proptosis. To assess someone suspected of having hyperthyroidism, a thorough approach is required. We begin by asking about symptoms, any recent non-thyroidal illness, drug treatments, and risk factors for thyroid disease. A physical examination focuses on typical signs, including goiter and signs of Graves' orbitopathy. Blood test requests to check the serum TSH level as a first step, measuring FT4 and FT3 in the same sample if TSH is suppressed. If subclinical hyperthyroidism is suspected, rechecking thyroid function tests after 3 months is a key step to rule out transient causes. We might also consider additional blood tests like inflammatory markers and thyroid autoantibodies depending on the clinical picture. When it comes to management, if serious complications are suspected, emergency admission may be necessary in a patient with thyrotoxic crisis. An urgent referral to endocrinology is warranted if there's a suspected pituitary or hypothalamic disorder. For all patients with new-onset overt hyperthyroidism, a referral to an endocrinologist is required. In particular, if the person has a goiter, nodule, or structural change in the thyroid gland, or if malignancy is suspected, then refer using a suspected cancer pathway. Persistent subclinical hyperthyroidism, especially if TSH levels drop below 0.1 microunits per liter at least 3 months apart with evidence of thyroid disease, also calls for specialist input. For those experiencing adrenergic symptoms like palpitations, tremor, tachycardia, or anxiety, beta blocker treatment can be beneficial in primary care. Usually, specialist advice should be sought regarding the initiation of antithyroid drugs. It's important to provide patients with information and support resources, ensuring that those on antithyroid therapy or other treatments follow specialist recommendations regarding adverse effects and regular blood monitoring. 2 commonly used antithyroid medications are carbimazole and propylthiouracil. These are used to decrease thyroid hormone synthesis by acting as a preferred substrate for iodination by thyroid peroxidase, the key enzyme in thyroid hormone production. A full blood count, including white cell count and differential and liver function tests, should be checked before initiation but not during treatment unless there is clinical concern of severe suppression of white cells in the blood. This causes early signs that are non-specific, often resembling flu or a minor infection, sudden sore throat, mouth ulcers, fever, chills, or fatigue. Your GP should seek advice regarding counseling or treatment pre-pregnancy for all women with overt or subclinical hyperthyroidism who plan to conceive. Immediate medical advice should be sought if pregnancy is suspected or confirmed, and all pregnant women with current or previous hyperthyroidism require urgent specialist referral. Following childbirth, thyroid function tests should be checked postpartum based on specialist guidance. So when can you ask for a thyroid test? Your tiredness doesn't improve with rest or time off. Your mood feels unbalanced or unlike you. You're gaining or losing weight without changing your eating habits. You've noticed changes in your hair, skin, or menstrual cycle, or burnout symptoms persist despite reducing stress. Remember, thyroid disorders often disguise themselves as everyday stress or exhaustion. A simple blood test, including TSH, T3, and T4, can offer clarity and prevent long-term impacts on your well-being. I hope you found this helpful. Don't forget to like, share, and subscribe to the channel for more educational videos like this.